So this study looks at a combination of treatments using onabotulinumtoxin type A to treat patients who have chronic migraine, and then the treatment is added with the CGRP monoclonal antibody being the add-on treatment. And these patients were obtained by recruiting patients from within my practice, which is a tertiary care headache center in San Diego. And these patients were chronic migraine patients who at baseline had over 20 headache days a month. And then they came into clinic, they got diagnosed. And what typically happens in the US is before a patient can receive onabotulinumtoxin type A, they need to be tried on 2 oral preventative medications like topiramate or amitriptyline. And only if they don't do well with those treatments, say they get a side effect or the efficacy is not good, then they can proceed to onabotulinumtoxin type A. So the patients included in this analysis had failed on 2 oral preventative drugs at a minimum and had been receiving onabotulinumtoxin type A treatment for chronic migraine for at least 6 months. So at least 2 treatment cycles, 3 months apart. The majority of the patients in the analysis had actually been receiving treatment for many years, not just the 6 months. That was the minimum requirement. And they had shifted from a baseline of 20 headache days a month to 12 headache days a month. If we look at the guidelines for the use of monoclonal antibodies targeting CGRP, the guidelines recommend using a CGRP monoclonal if the patient has more than 4 disabling headache days per month. So these patients, even though they had done very well on onabotulinumtoxin type A with significant reduction, and they'd reduced by 8 days, they still had 12 bad days. So as a result, they were good candidates for the addition of a CGRP monoclonal, which we did add. And this was done shortly after the CGRP monoclonals came to market, which in the US was in May 2018. And the first CGRP monoclonal antibody that came to market was iranumab. And in the beginning, we were using iranumab at 70 milligrams a month. That was the typical dose. So the majority of the patients that are included in the analysis got iranumab at 70 milligrams. There were some that got it at 140 milligrams. And then as the other CGRP monoclonals came to market, these combinations were also used. Now, when we look at the results of the combination of these 2 treatments, we see that on average, these patients reduced by another 4 headache days. So they shifted down to 8 headache days. In other words, they did not become headache-free. They continued to have 8 days on both treatments. But there was a significant effect by using the combination, which we were not going to achieve with monotherapy. If the hypothesis is that the monoclonal would have achieved the full benefit without the onabotulinumtoxin type A, then I would have anticipated seeing a much more robust response than just the 4 headache day reduction that the additional treatment provided. Now, the argument against this is obviously the cost of this type of approach, but if you consider the individual patient who now has 4 more productive days per month, those 4 days over the course of a year would be 6 weeks. So that individual patient just gained 6 additional weeks of productive life. So in my view, that is well spent on this select group of patients who are not easy to treat.